My regards to our President, Dr. Shashank Kumar Sir, our General Secretary, Dr. Abhishek Chandra Sir, Dr. Shalini Mohan Ma'am, who's the Chairperson of the Scientific Committee, for keeping the academic series going month after month. So we have a rich hour ahead. We begin the keynote address by Dr. Arup Sir, uh, followed by four eminent speakers. I also welcome the chairpersons for the evening, Dr. Anupam Ahuja from Aligarh, Dr. Anshu Arora from Noida, and Dr. Sarita Agarwal from Ghaziabad. So they will take the discussion forward after each talk. So let us begin. We'll start with the President address by Dr. Shashank sir.
I think Dr. Shashank is going to join in a few minutes.
Okay. So we'll start with Dr. Abhishek Chandra sir. Sir, if you can say.
So hello everyone. I heartily welcome you all for this new webinar series, which is regularly going on for the past few months from UPSOS. And Dr. Shalini is taking a great effort to hold it every month. And we all are, especially the residents, are greatly benefit with these kind of series. And Dr. Pranav is an excellent retina surgeon. He is the moderator today. And we have eminent speaker, Dr. Roop Chakravarti from Trivandrum. He has been so active throughout his career. And I have heard his lectures before. And it is really very knowledgeable to hear his lectures and his presentations. So I invite Dr. Chakravarti for this lecture series. And Dr. Shashank has also joined. So Dr. Shashank, can you please unmute yourself and give a brief introduction about the program? Welcome, our President, Dr. Shashank.
Hello, good evening to everyone. This is a complete webinar, and we have conducted this, we conduct every month based on the last Saturday of the month. And today's speaker is Dr. Chakravarti. He is a well-known ophthalmologist in India. Unfortunately, I was his MBBS junior at JIPMER 1982, and when I did fellowship from Arvind IIT, he was senior there, and he was like teacher to me. So we are proud to hear him today and our knowledge. So welcome Dr. Chakravarti to the UPSOS webinar. Thank you. Dr.
I'll just give a brief introduction of Arup sir. Arup sir is a senior consultant and director of Chakrabarti Eye Care Center at Trivandrum. He is an MBBS and MS from JIPMER Pondicherry, and he is one of the most respected names in complex cataract surgery in our country. He is the past president of KSOS and editor of AIOS proceedings from 2017 to 2023. And he has also been a fellow of the American College of Surgeons and a member of International Intraocular Implant Club. He has conducted over 210 instruction courses at ASCRS, ESCRS, and all the international conferences, and delivered more than 15,000 faculty presentations, authored over 76 papers, and edited 3 books on cataract surgery and its complication. He speaks tonight on mastering the details, surgical pearls for outstanding PICO results. Sir, a warm welcome from the UPSOS family, and the floor is yours.
Can you see my PowerPoint?
Yes, sir, we can.
And am I audible too?
You're audible too, yes.
Yeah. So good evening all, and thanks a lot, Pranav, for the very kind introduction. And it is so nice to see old friends from Uttar Pradesh, and I'm really honored to be invited to give a keynote address today. I have been doing FICO for the last 35 years. And in this long journey, I have picked up many pearls, many pebbles, and there's a vast collection. So in the time allotted to me today, I'll be able to share few of the pearls which I have picked up by experimenting from my own experience or looking at videos by presented in various conferences and learn from various journals, video journals, and a few pearls for you here. Now, today we all of us, most of us prefer the chop technique because most of us deal with hard cataracts, and a chopping technique is generally suited for a hard cataract for various reasons. So before you uh, select your technique, the technique that you're going to employ for your nucleus disassembly, make sure that the technique is user friendly so that almost everybody can use it. It is reproducible so that there is a set pattern. There is not much of surprises and unexpected events. The whole process should be very safe, and the long-term outcomes should be very encouraging for the patient as well as for the surgeon. So it requires a proper, a great deal of preoperative surgical planning. And for me, when I chop a nucleus, I go through three steps. The nucleus disassembly. First is debulking, then once that is done, then dismantle the rest of the nucleus. And once the nucleus has been divided into multiple fragments, consume the fragments. In certain situations, I may bypass step number one, debulking, particularly for very brittle cataract, and go straight away for dismantling and then fragment consumption. And all the while, when you're focusing on the nucleus management, make sure that you do not lose the forest for the tree. So you must be aware that you are surrounded by the corneal, your instruments are surrounded by the corneal endothelium, very delicate structure. There is the uveal tissue, there is the posterior capsule. So you have to have a total control over the intraocular milieu in these cases. Now, it is very important to choose your devices. When I'm operating on a very hard cataract, grade 5, grade 6, I always prefer the Chang vertical chopper, which is about 2 or 2.5 millimeters in overall length. And other categories of hard cataract, I prefer the vertical chopper. In certain situations, even the Sinsky hook also does pretty well. Horizontal chopper basically is not used for for the chopping that I'm going to talk to you about today, but it was very useful when it was described by Nagahara in the early 1990s, and I had done a great deal of horizontal chopping with this, but I don't use it as a routine. It is also important for us to choose the phaco needle, phaco tip that we use to disassemble the nucleus. Now, if I'm using longitudinal, I use the Goider mega tip, and I have nothing financial in whatever I'm talking today. This particular mega tip goes through a 2.8 millimeter incision. It has three ultrasound generating surfaces: outer surface, middle surface, and the inner surface. So when you start chopping and when you aspirate a large chunk of nucleus into the phaco needle, there is always a possibility of the needle lumen getting blocked by the hard nucleus, or even the tubings down the line can also get blocked. So then you have the second surface, which further carries out another round of emulsification, and then the innermost, the ultrasound generating surface, where the nucleus is further divided and pulverized before it enters the needle. So you don't get much of wound burns and this sort of complications when you're using a mega tip. And if I'm using the torsional, go for the balance tip, and I always make it a point to switch off the auxil torsional when I'm doing chopping. But when I'm sculpting, I always use the auxil because this is a very powerful tip, and it cuts through very hard degrees of nucleus, almost as good as the mega tip from the various other longitudinal handpiece machines, on the delivery machines. So on the other hand, when I start chopping with the Centurion, I switch off the auxil torsional. I just use the longitudinal, and it gives me a very good chopping. And once the fragments are generated, I can come back to torsional, and it maintains a very good chamber stability, and it allows you to remove the residual chunks of nucleus very rapidly. Now, let me take you through a series of cases. This is not a very hard cataract, but if there are some early beginners here, I think they'll find it easy to understand the technique that I'm going to follow. So here, I have created a vertical wall at the center of the nucleus. And then I go at the depth of the wall, engage the nucleus with a high vacuum, high aspiration flow rate, and my left hand chopper only moves. So this is actually neither vertical chopping nor horizontal chopping. It is the chopping starts from the rexis margin. So it is oblique chopping or diagonal chopping. This is something which is taught by David Chang, and it is mentioned in his book. So once you have seen the chop line, it is not really necessary for you to bring the chop line all the way to the opposite pole, opposite like sub-incisional area. And as long as you are sure that you have chopped the nucleus completely, which has extended up to the center, that is more than enough. You don't really have to struggle beyond that. So then, here, as you see here, I've divided the nucleus into multiple pieces. If it is a harder cataract, I would like to divide the nucleus even, at 6, maybe, or 8 pieces. And if it is not a very dense nucleus and it's a deep and anterior chamber like myopic eye, post-vitreotomy eye, in that case, sometimes I'll just go ahead with 4 pieces of nucleus. So the idea is that this will enable you to do phacoemulsification within the capsular bag, away from the corneal endothelium. So this is the way the fragments are generated, and then they're consumed. So fragment consumption is not a very difficult matter. Now, this is the next degree of hardness. So here, if you see, I have stained the anterocapsular trypanal blue dye, the larger rexis, about 6 millimeter rexis. Instead of making a groove here, vertical wall, I made a central well as deep as possible. Then I find that but the parameter settings which I've used is not enabling me to get a good chop. The nucleus is rotating. So I would increase the phaco power a little bit, vacuum a little bit, aspiration flow rate a little bit, tackle the nucleus at a deeper plane, and start chopping. So once you see chopping goes on like the way you saw it so easily it happened, you know that you're working with the right parameters for separating the nucleus into multiple pieces. So again, you see here, I make no effort to bring the chop line up to the center, which means, my lateral separation movements are very, very minimal, and this does not traumatize or jeopardize the capsular bag stability. So here, most of the maneuvers are happening at a deeper plane. Now, if I am dealing with a very hard, very big, thick nucleus, and it is filling up the intercapsular bag, then I would remove the first chunk of nucleus, decongest the capsular bag to a certain extent, and then make the subsequent manipulations. This is a little harder degree of cataract. So here I'm not restricting myself to just a deep well at the center of the nucleus. I am going to make a tunnel. First, of course, you have to aspirate the superficial lens matter. Otherwise, sometimes you may have a false sense of depth. There are a lot of fluffy stuff, and you may be thinking that your phacoid needle is buried inside and you're deep inside the eye, inside the nucleus. It is not so. So it is important to remove the superficial stuff so that you start working on the nucleus. Please make sure that you sculpt deep at the center. In the it's a disc. The nucleus has the shape of a disc. In the periphery, you don't go too much into the depth. So here I have used I'm going to use a stop and chop technique here, and see sculpting is done at multiple points. I've injected a dispersive OVD. Dispersive OVD protects the corneal endothelium, and it also neutralizes the free radicals which are generated when I use a lot of echo power. So here, see, chopping becomes very easy because my peripheral portion of the nucleus has been thinned out. So again, let me show it in slow motion. I bring the nucleus slightly towards the center and then start the oblique chopping or diagonal chopping. I don't go up to the fornix, not necessary to go up to the fornix. It may not be also safe with a Chang chopper to go up to the fornix. So now I have brought the chop line almost up to the center, and I know that I'm using the right parameter settings and I don't have to modify much. So I use the same settings and sequentially chop the nucleus into smaller and smaller pieces, as you see here. And it is again very important for you to put in as much of dispersive OVD as you want to, which will give you a very good crystal clear sparkling cornea on postoperative day 1. Now, these kind of patients will always have a thick leathery plate on the nuclear plate. So that is the reason your sculpting has to be very deep when you're working at the center. Otherwise, you have the 2 pieces of nucleus which are not separated at the center. And if all the pieces of nucleus are joined at the center like a flower petal, then the surgical manipulations may become a little more complicated. You may tend to bring the nucleus into the anterior chamber, or you may end up making all sorts of avoidable manipulations, which may result in complications. So, a little bit of sculpting, maybe further sculpting may be necessary. we find that a chop line doesn't go through the leathery nuclear plate. And then once it has been thinned out, things become much easier, as you see here. And then because the Rex is slightly larger, it is you see the nucleus tending to prolapse into the anterior chamber. So use try to push them back into the bag and use dispersive OVD and get multiple bite-sized pieces. And when I have divided the nucleus into multiple pieces and remove the parameters, remove the nucleus chunks, my vacuum comes down, aspiration flow rate comes down, so that post-occlusion surge definitely becomes much lesser. And my left hand paracentesis, I do a bimanual irrigation aspiration, so by chopping from the left hand. So till irrigation aspiration time, my left hand paracentesis, upper paracentesis will be smaller, so that there is a tight fit between the chopper and the paracentesis, and there's no leakage in from the anterior chamber, and there's no chamber stability. Now, this was an Anglo-Indian lady. We have a legacy of them in southern and central in southern Kerala, who were tea plantations and working. They had rubber plantations. So one such lady came here, a black cataract, and she wanted surgery. And then so here I decided that I go back to my old stop and chop technique. So please do not think that all chopping is a technique which is suitable for all kinds of cases. Here in a very thick case, I would not like to go for a direct chopping. Direct chopping meaning, without debulking the nucleus. So I'll try to debulk the nucleus as much as possible, particularly the central area. Use a copious amount of a dispersive OVD to protect the corneal endothelium and neutralize the acid, the free radicals that are generated. And go a little carefully when you approach the periphery, because here the posterior capsule is closer. So then again, I'm using the Feco tip and the Sinskey hook. I get the chop line, I get the crack line, and then gradually bring the chop line towards the subincisional area. Don't try to use brute force to separate the nucleus into two halves. That way you'll end up with stretching with capsular bag stretching, zonular stretching, and there may be disasters associated with that. So be very gentle, and when there is some additional force is required, you do a little bit of sculpting, go deeper towards the posterior nuclear leathery plate, and then you try to separate the nucleus. So now I have separated the nucleus quite easily into two pieces. So anybody can do this sort of cases. It is not difficult. Only thing is you need to be patient. You need to have self-confidence. You need to have the proper surgical technique, proper instrumentation, a proper idea as to what is going on, and of course a proper idea as to when to give up. In certain cases, you realize that it happens even in my hands today, that there's not much of progress, and I feel that continuing with phacoemulsification may not be safe. So I would bail out a safer non-phaco technique. So now it is going the old the Paul Cox stop and chop technique. So stop and chop technique definitely works pretty well, particularly when I'm dealing with extremely hard cataracts. So this is the first post-op day. So most of us we show a very daring case, a lot of daredevilry, hard cataract, but then we don't see how the patients look like on the first post-op day. First post-op day, you have to ensure that the patient gets a crystal clear cornea. Otherwise, there's no point. Otherwise, you please do an SICS or maybe an extracapsular surgery if you are not able to protect the corneal endothelium and have a crystal clear cornea on day one. So I also operated on the fellow eye of the same lady, and she did extremely well. So basically, these are some of the take-home points. Please, for the youngsters here, do not assess the degree of nuclear sclerosis under the microscope, because sometimes you may have a fantastic red reflex, but you may be dealing with a very hard rock. So slit lamp evaluation of the nuclear sclerosis is paramount. Always stain the anterior capsule with trypan blue dye, because many of these patients, there may be arcus senalis, crocodile chagrin, and if you have not stained the anterior capsule, you lose the rexis margin, and you may end up phacoing the rexis margin, or even chopping the rexis margin, which may give you a wraparound tear and complicate the whole process. Soft shell technique is must, and that's what I routinely use for all my patients. These hard cataract elderly patient scenarios, they tend to have a thin posterior capsule, particularly the elderly females. So be very careful when you do the hydrodissection. Be very gentle, and if you burp out the OVD from the anterior chamber, otherwise you may have a pupillary snap in these kind of cases. And if I'm using longitudinal, use megatip, torsional, balance tip, and that is used only for sculpting as well as fragment consumption. But I use longitudinal when I'm chopping, as I mentioned earlier. And you must take all precautions to avoid wound burn. And most of these advanced machines, they do not, they're not associated much of wound burn. I hardly see them. I hardly see them about last 15 years or so. Try to restrict your activities within the capsular bag so that all the fluidics, all the turbulence, nucleus movements, everything is within the capsular bag. There may be a potential for lumen occlusion. For example, so one sec. At the needle and tubing. So I'm not telling that it is foolproof. There could be some lumen occlusion, which at the level of the needle phaco tip or at the tubing. So you must have an alternative for that. So instead of flushing out the tubings or handpiece, you may change the needle, you may change the tubings. And another thing that I have noticed over the years is the small residual nucleus chunks. They they may be associated in higher numbers in these challenging situations, because when you chop, you have small chunks of nucleus which may hide in the angle, this thick arcus senilis, and you don't see them till the patient comes back at first post-op day or seventh post-op day. Sometimes the small chunks may go behind the iris and hide there if the nucleus come down. So whenever I see a small chunk of nucleus, when I'm tackling the nucleus, I forget the rest of the nucleus and just remove the chunk before the nucleus, small chunk of nucleus, so that it doesn't have any opportunity to hide anywhere. And I'm sure with these techniques, with these tips, your heart cataract chopping technique should do much better. Now, in case you have a situation where you have a thick epinuclear, the leather nuclear plate, post-nuclear plate, now you can use this technique. Inject a cohesive OVD uh, through the peripheral separation that has happened, push the posterior capsule posteriorly by creating a safe zone. Take two Sinskey hooks, as I'm showing here, and then very gently you walk the cleavage line from the periphery to the center. And then, of course, you have to have a capsular bag that is filled up. You have to have the anterior chamber that is deep enough. And this process, you should not be traumatizing or stretching the capsular bag. So now the nucleus has divided into I have divided the nucleus into two pieces, and subsequently, phacoemulsification will be quite easy. And in certain situations, for example, hard cataracts and small pupil situations, here again, the cornea doesn't look very clean, very clear. You may not have much visibility, particularly if the patient is moving around a lot. In that case, this technique using double Sinskey hook to separate the nuclear, to separate the nucleus which are joined at the center or even at the periphery, it's a very useful technique. It may take a little time, little patience, but then at the end of the surgery, you find that you took a right decision. Now, I'll just talk a little bit about, soft cataract situations. So I've dealt with hard cataracts. People say that soft cataracts are very difficult to tackle. Now, in my definition, a soft cataract is one which you cannot crack. If you are able to crack it, chop it, it's not a soft cataract. As it is a routine cataract. If you're able to rotate a nucleus, again, it is not a soft cataract. So soft cataracts are ones which you can aspirate with the irrigation aspiration, standard irrigation aspiration cannulas or handpieces, and which you can other techniques can be performed. So this is a technique that I employ for post-polar cataract, and it can definitely be used. It is not playing. So just let me someone is not playing. What I would do is, I make a rexis about 4.5 to 5 millimeters in size. This is the temporal side and this is the nasal side. So I will debulk the lens matter from the central bag and the nasal side of the bag, and no hydrodissection done. I don't even perform a cortical cleaving, hydrodelineation. Cortical cleaving hydrodissection is out of the question. I do a mechanical hydroseparation where I pass a cyclogelysis spatula under the anterior capsule, sweep it around 360 degrees, separating the lens matter from the anterior capsule. And then when you're removing the central chunk of the lens matter and the nasal chunk, passive hydrodissection happens. So fluid flows under the capsule in the subincisional area fornix. So you should be able to displace the inaccessible lens matter with your Sinskey hook from the paracentesis, or sometimes visco displace it, inject visco into the capsular fornix. And then the lens matter is pushed to the center in a more accessible area. So all kinds of soft cataracts can be managed by using this technique. I think the final video is about the improvisation of so many soft shell techniques, ultra soft shell techniques with deviation of a tortoise. This is a patient for a toricide. And toricide, we don't want to have any visco, any OVD behind the lens, because then you have to remove it completely. Otherwise, the nucleus of the lens is going to rotate. So here, what I'm doing is I'm using Helon 5 just to fill up the anterior chamber. You could use Helon GV also, but Helon 5 gives a better result. It stays there, it deepens the anterior chamber. And then I would be injecting BSS into the capsular bag. So we have a capsular bag that is kept open by BSS, and the BSS doesn't come out because there's Helon 5 in the anterior chamber. So the toric lens is inserted, and you rotate it and put it in exactly the same axis where you want it to be, and because you don't really have to go behind the nucleus, and there's no chance, no question of any nucleus rotation while you remove the residual OVD, because residual OVD is only in the front of the lens. And once you just burp out the incision and you just do a little bit of irrigation aspiration, the OVD comes out. So this is a technique which has allowed me, to perform a torical implantation where I'm very sure about where the lens has been kept. The lens doesn't rotate. There's no slipperiness of the capsular fornix for the haptics to rotate, and it has given me a very good outcome. So thank you very much for your kind attention. And it is a topic at each and every step and stage of commercialization. There's a lot one could discuss, but I think what I have done today is okay enough for the day. Thank you very much for the opportunity.
Thank you so much, sir. Those videos were really a masterclass. Every one of them had a different challenge and a different pearl. And to see black cataracts handled with that much calm and control is something all of us will carry back to our operating rooms. May I now request our chairpersons to take the discussion forward? Dr. Anupam sir, Dr. Anshu, and Dr. Sarita.
Hello everyone. So excellent videos and excellent presentation actually. So I just wanted to ask one thing. There are so many PGs also joined this webinar. Although all the steps in phaco surgeries are very, very important for the better outcome. So what is your message to postgraduate, which is a single step they should master so that they can excel their phaco outcomes?
From the postgraduate level, I would say that they should learn to do a safe SICS in these kind of situations. All right, I would not ask them to start FICO because the way the situation is in the country, the medical education and the hands-on our postgraduates get, with due respect, I mean, all of us have gone through that stage. So I mean, you can take up these challenging cases maybe after you've done about 80 to 90 or 100 cases, not before that. So till that time, I would say that use FICO emulsification in a supervised manner for routine cases, not for hard cases, not for challenging cases. But you must, hone your SICS skills. SICS is a wonderful technique. I mean, I have also been using this technique for along the same time that I've been doing FICO. If I'm doing an SICS here, they would make a larger exercise so that bringing the nucleus into the anterior chamber becomes easier. And instead of a maybe 5 or 6 millimeter incision, I may go for a 7 or 8 millimeter trapezoid incision or with a back cut. So the nucleus removal can be easy. So go for larger exercise, number one. Number two, use plenty of dispersive OVD. And third thing is, don't economize on the incision size. If you have small incision in such a hard cataract, this is a brown cataract, you cannot differentiate between the iris and the lens matter. And you try to pull out the nucleus using the sandwich technique, you may end up even traumatizing the iris or tearing the iris from its roots. So these would be my points for the young postgraduates who are graduating into FICO. Not to take up these cases now at this stage, but at a later stage, and do SICS for is a hard cataract situation.
That's correct, sir. That's correct.
Good evening, sir.
Good evening.
Fortunate to witness one of your master classes again. Thank you. I just wanted to know if there's any role of manual pre-chopping in hard cataracts, and does it reduce the phaco burns and stuff?
Oh no, so I think it's a very valid question. There was a phase when pre-chopping it became extremely talked about. I won't say it was very popular, but extremely talked about. Takahashi used to do. He was from Japan. He was the one who used to show a lot of videos in the ASA. I think between 2000 and 2008, 2009. And then there's another surgeon from Ike Ahmed's mentor. No, get his name. So they are the only two people who used to do a lot of pre-chopping and show the videos. But I was also carried away by these videos. They're very, seductive videos. They look very nice. But then I got the choppers from ASICO, from the meant for soft cataract, hard cataract, and nucleus cutting board and stabilization board. But they become blunt quite off very fast. And for really hard cataracts, there is no predictability. The soft cataract is easy. And it's for that matter, anything works well for soft cataracts. I'm talking about the kind of cataracts that I showed here. I don't think it is really very safe to use a pre-chopping technique for these cases. But I mean, you could, for example, when if in a hard cataract, if you're sculpted so deep, then maybe you can use a Kratz kind of chopper. The cross sections chopper. You go to the bottom of the tunnel and then spread the limbs of the chopper and the instrument, and the instrument will separate the two pieces of nucleus. But or you can do it bimanually using two Shinsky hoops or two cyclotelic spatulas. But I would not be any venturing out doing pre-chopping for extremely hard cataracts. No.
Thank you, sir.
Dr. Anshu, sir, if you want to comment.
You're not audible. Please unmute yourself. Yes.
Yeah, great presentation, sir, as always. But I'm primarily a retina surgeon, but lovely surgeries. The only thing, which sometimes troubles me as a cataract surgeon myself, is not about dealing nucleus, but sometimes epinucleus, which starts under the, the incisional area. So what would you advise in such cases where how to deal with an epinucleus which is subincisional and not coming out easily? Do you, go ahead straight with, irrigation aspiration and try to remove it? Is it safer that way, or do you have some tips under your?
Now, actually, I have a separate presentation on tackling of epinucleus. Maybe we'll keep it for another day, the videos. So, but what I would do is I try to avoid having an epinucleus. A very tough situation is one where you have a very thick epinucleus and a small pupil and an uncooperative patient. It's a very difficult scenario. So my first thing is, I try to avoid having an epinucleus. So I don't do any hydrodelineation. It is hydrodelineation that results in the epinucleus. And you are likely to get epinucleus only the softer degrees of cataract. So I'm very, very careful. I do a very safe, you tint up the anterior capsule, then inject the fluid. So inadvertent hydrodelineation and the goldening may happen. Rarely, it can still happen, but you cannot rule it out, but the chances are very less. Now, supposing after all the precautions, you still ended up with an epinucleus, some of the machines have an epinucleus mode. Epinucleus mode, like, vitrectomy mode, epinucleus mode. So you can,
Yes.
you can, it's a very low phaco power and appropriate vacuum and aspiration flow rate. So that way, you can clump up, you can actually aspirate the epinucleus at the tip of the phaco tip, and then using any further parameters, without using, you just pull it toward the center. The whole thing kinds of collapses and comes out. If it does that, you are very lucky. But sometimes, when there is the epinucleus in the periphery, it is not near the rexis margin. So you'd not be very comfortable going to the periphery using a phaco handpiece. So in that case, you have to use irrigation aspiration. But before that, what I do is I'll just take my OVD, and OVD will scrape the anterior capsule under the anterior capsule, go to the fornix and inject OVD. So sometimes if you have injected OVD in the right plane, the whole epinucleus is sort of bunched out and it comes to the rexis margin, and it is a more accessible area. And once it comes there, then you go with the bimanual irrigation aspiration, put the irrigation cannula under the sheet of epinucleus and then elevate it anteriorly and then remove it. Sometimes it is easier to remove it from the main incision. Irrigation goes on through the sideboard, and the epinucleus which you have brought in the anterior chamber, because some of them are very sticky, it may take a long time when you do a bimanual irrigation aspiration. So you can express it from the main incision.
Thank you, sir.
Another thing one could do is, using a Shinsky hoop, you can just rough up very carefully, even in the posterior, the epinucleus is overlying the posterior capsule. Just keep scraping, then till you get to the posterior capsule. Once you've got there, then you can always inject visco under that, and the epinucleus on the posterior capsule sort of wells up, bulges up, and then it is easy to remove.
Hello, Dr. Akru. I'm Dr. Abhishek Chandra. Thank you so much for your wonderful videos as usual. There are just two questions from my side. One is, how is your Chang chopper different from a normal vertical chopper in cases of very hard cataract? That is the first question. Yeah.
So Chang chopper, like if you think about a Sinskey hook, it is like a Sinskey hook on steroids. It's a much bigger, it's like conical, it's a conical thing, and the tip becomes sharp.
So in a vertical chopper, also the tip is sharp. And what is the length of this Chang chopper in hard cataract? What you use?
The vertical chopper, actually, it is, if you take the cross section of the Chang chopper, it is round or oval.
Okay.
Okay, but if you take a cross section of the standard vertical chopper, that is sort of a linear kind of curve. It is not round or oval. So for a Chang chopper, it is important that you go to the depth of the nucleus as much as you can and start chopping.
So don't you think that the chopper inner side should be cutting so as to break the nucleus into two parts more efficiently?
No, it is not. See, if you see the technique here, it is, if you think about the chopping, initially it was a vertical chopping, karate chopping. With the vertical chopping was described.
Yes.
You had an instrument which has a cutting edge, and you go to the substance of the nucleus and approximate incisions like that,
Yes.
It is not safe for a hard cataract, because if it is a hard cataract, you do not know how much deep your phaco tip has to be in that given case, and how much force you're going to use to do a karate chop. So it is very, very unpredictable. So that is the reason those hard cataract situations, I'll do as much sculpting as possible to debulk the central area. And once you have done, there's no need for any vertical movement as such. It is a horizontal come vertical. You're going into the substance of the nucleus with a phaco tip, sharp phaco tip, and then approximate the phaco tip towards approximate the chopper tip to the phaco. So then again, a component of horizontal chopping comes in, and then lateral separation. So lateral separation also is part of the chopping technique. It works out.
Okay. And the another question is, I was seeing a video, you're using two types of tip. One was the Centurion tip, which was like a curved tip, and
balance
the second and the second tip was like a guider's tip. So do you change your tip in Centurion also? Do you use guider tip with Centurion machine also?
They're not interchangeable.
Yes.
They're not interchangeable. So when I'm using the Centurion machine, when I'm chopping, I don't use the torsional.
Yes, that's fine.
I use only longitudinal.
Yes.
Okay, because if it's torsional in hard cataracts, I am not very happy with the grip that I have on the nucleus.
Yes.
So I use longitudinal, and it works very well in my hands.
And
for
break it with the same tip.
Yeah. And for the other machines, they don't have torsional, so longitudinal, and they cut extremely well. The Megatip, for example, it has the purchase power on the nucleus is phenomenal. Even with the vacuum of 300 to 400, it can stabilize the nucleus like just one unit. Phaco tip of the nucleus is one unit, and very easy to chop it.
So which machine is your favorite machine for phaco solution? Centurion or a different one? So that's a personal question. No, I think you can answer that.
See, if I have a VIP and very hard cataract, then I'll take the guided machine.
Okay.
I mean, the Megatip.
And guided tip with which machine? With the guider machine only, or with the?
Yeah, no, it doesn't fit in the other machine.
Okay.
So the Megatip design has been copied by other companies. Early copied it, and
Atlee is doing the same. That's why
there were some issues. They went to the court. I think Goida got some compensation from Atlee. But then these tips cannot be fitted in other handpieces.
Okay, thank you so much, sir.
The problem with the Megatip is, you require a 2.8 millimeter incision. Less than that, it's very difficult. On the other hand, with our Centurion, you can go even through a very much smaller incision than that.
So do you have any experience with the new Unity machine from Alcon?
No, I have not used it.
Okay. Thank you so much, sir.
What do you think about it?
Sir, I think it's a good machine, but the cost which they are giving is too high. And there is not much benefit. There is definitely some benefit over Centurion, but I don't think there is much benefit with the users whom I have talked about. There's only a increase, less FACO time which is there, and slight increase in the safety, which is very good either way with Centurion also.
No, what they claim basically is, they show in vitro experiments with the
Yeah.
Centurion handpiece and with the Unity, and they say that in similar type of nucleus, it reduces FACO energy by 40%.
Yes.
Even CD is also is reduced. And they said 4D. I have not got a satisfactory answer to what is 4D. What is the fourth dimension? So basically, torsionalysis itself is in it's a 4 dimensions because it is X, Y as well as Z. It is moving up vertically. In fact, the transversal, which was with Johnson Johnson, also it had this kind of movement. So what exactly is the 4D, fourth D? Then they said, no, lucky, it keeps on moving all over the place, and they themselves don't understand, the people who generally come to explain, and it cuts extremely well according to them. But then what I find that it's a Centurion cuts extremely well.
Yes.
For the need to have a machine which is better than that. And second thing is, chamber stability with Centurion is with modern machines is really good. You can't complain about the chamber stability. And plus, okay, you could reduce the CD. Okay, now, I mean, we have been using for how many, 35 years, how many of our routine patients have gone in for corneal decompensation? Okay, so, I mean, the CD which we usually get with the other machines may not be that traumatic to the corneal endothelium to the extent that it will cause corneal decompensation in all cases that you operate. But I believe it has many advantages for post-segmental surgeon. That is the main advantage.
Yes. Thank you so much, sir.
Welcome.
Thank you, sir. So that was a wonderful discussion. Thank you, Abhishek, sir, for joining in. Let us move on to the next speaker. Next speaker is Dr. Anu Jain. She is an associate professor at SN Medical College, Agra, and she will be presenting on fulminant tubercular endophthalmitis in an immunocompetent female. Ma'am.
Yeah. I'll just share my screen. Yeah. So my screen is visible now?
Yes.
Yeah, okay. So good evening, everyone. At the outset, I would like to thank the scientific committee UPSOS and Dr. Shalini Mohan Perse for giving me this space to bring along this interesting case of fulminant tubercular endophthalmitis, which is a case of ocular destruction, diagnostic silence, and subclinical systemic threat. So just a background before going on to the case. TB is the world's largest leading cause of death due to single infectious disease, and it was responsible for about 10.8 million new cases and 1.25 million deaths in 2023. And of this global burden, we as a country contribute 25%. We all know that TB is a great imitator with myriads of presentations. Typical phenotypes of ocular tuberculosis, they include serpiginous-like choroiditis, choroidal tuberculomas, occlusive retinal vasculitis, and anterior granulomatous uveitis. Diagnosis of ocular TB is the greatest rider in the institution of prompt management. So my case today, she's a patient, 22-year-old female, immunocompetent, who presented with us with sudden and severe diminution of vision, redness and pain in her right eye for past 2 days. There was no systemic illness apart from an episode of fever and vomiting 10 days prior to the presentation to us, for which she was admitted by some local practitioner and was given some IV fluids and injectables, and that made her all right. There was no present or past chronic illness and no positive history. On examination, the right eye had BCVA of 1/60. Cornea was mildly hazy with an AC reaction of 3+, and IOP was on a lower side. The fundus examination revealed a hyperemic optic disc with peripapillary edema, hard exudates, and intraretinal hemorrhages at macula. There were multiple foci of occlusive vasculitis with perivascular sheathing in the mid-periphery, and we could see a large circumscribed exudative retinal detachment measuring around 5 to 6 disc diameters along the inferotemporal vascular arcade with an overlying vitreous haze. So the left eye was absolutely normal. The B scan corroborated with the findings on the retinal examination. General examination was within normal limits. A contact history of TB was elicited but was found to be negative. So we went ahead with a working diagnosis of chorioretinitis, and we prescribed her broad spectrum antibiotics and some oral steroids. Meanwhile, the blood workup, it showed normal blood counts with a moderately elevated ESR and CRP. The serology for HIV was negative. Chest X-ray, USG abdomen, they were inconclusive. Mantoux was within normal limits. PCR for aqueous fluid was tested negative for Mycobacterium tuberculosis and the viruses. Pulmonology and internal medicine reference was also sought, but it was inconclusive. So what we had at hand was inconclusive results for standard diagnostic test in a rapidly deteriorating eye, and we had no clue to the etiology yet. On day 10, the vision had dropped to PL negative, PR was inaccurate, hypopyon had appeared, and there was severe vitreous haze. The USG was pointing towards endophthalmitis as the vitreous cavity was all full of exudates. So pars plana vitrectomy with silicone oil first, that was undertaken with vitreous fluid PCR again sent, and it was found negative for tuberculosis and the viruses again. 4 rounds of intravitreal antibiotics post vitrectomy were given. A repeat vitrectomy because of the continuing inflammation was again attempted. On post-op day 35, there were still ongoing inflammation. There was exudates along with the silicone oil, and the pressure was massive. She was in massive pain. The eye was blind already. So unfortunately, we had to take up the patient for evisceration. Then in the eviscerated tissue, the histopath showed the pathognomic caseating granulomas with Langhans giant cells and multinucleated giant cell and Langhans cells. And on the ZN staining of the ocular tissue, the eviscerated tissue, we found acid-fast bacilli as well. So the diagnosis was bang on now. It was tubercular endophthalmitis that we were dealing with. Again, we went to our lab test and radiology, or repeat Mantoux, IGRA, they were again negative. HRCT, pulmonology consultation, they said it is all right. But in the contrast enhanced MRI brain, we
I think the network is stuck.
Yeah, the sound is not coming. Dr. Pranav,
Yes, sir.
is the sound coming?
No, sir.
Yeah, the presentation has stopped.
Yes. We ask the next presenter to present, sir.
Yeah, you as
Is
IT
the
team.
screen frozen for me only?
No, sir. For
No, for everyone.
For everyone.
Yeah, the sound is
Actually,
also
the
not.
network has been lost.
Yes, I think. In the meantime, we can have a discussion upon this thing. The only thing is that she did a PCR for the vitreous sample, which was negative. So definitely it could be negative, but taking into consideration such amount of endophthalmitis with so much of inflammation, do you think, Pranav, you yourself a retinal surgeon, what do you think would be the reason for negative PCR for vitreous tap earlier for TB?
PCR is not 100%, sir. A lot of times
I know,
PCR can come negative, even in a positive end of case.
but it was such a
I just
fulminant
wanted to
case
see what was.
with hypopyon and so much exudative RD and everything.
Usually, sir, tubercular does not present
Yes.
in such a way. It's
Yeah.
mostly like a chorioretinitis. Maybe that was a subretinal exudate, which she was telling earlier, and that started spreading. And tubercular would have come because it even eventually in the end also it did not come positive, and sometimes PCR results can also be
The
negative.
presentation is too aggressive for tubercular.
Yes, sir. Yes, sir.
Yes.
I have
It's
not
not like
seen.
that
And
usually. Dr. Anshu?
in my opinion, it does look like starting with tuberculosis, and it must have been complicated with a secondary infection also, because usually they don't present so acutely. They are more like, fungal kind of end off.
Yeah.
They do more have vitreous presentation, and having and the PCR she mentioned was from AC tap, probably
Vitreous tap also.
false negative, not a vitreous biopsy which she looked into, and it was primarily an AC tap which she used. It should be positive, be it AC tap or be it vitreous if it is tuberculosis. But I believe there must be a secondary infection along with the tuberculosis which has caused this, because what she got later with the a biopsy result probably has shown the subretinal lesion which was tuberculosis.
Right.
So there must be some underlying immunosuppression and some kind of other infection in the body which has come to the a complicated endogenous endophthalmitis kind of picture.
Do you think there is
Atul
any
sir is
relation
also there.
between the intracranial lesion and this endophthalmitis?
Pardon me, I didn't get it.
Do you think there is a relationship between the intracranial lesion which he was showing in the end with this endophthalmitis?
Difficult to say. Difficult to say. I don't think there are multiple other infections also which can present that way. So there is no direct correlation. I would suggest might be possibly.
Yes, Dr. Anupam, any views on the same thing?
Sir, could we consider cysticercus in this? That lesion in the brain could also be cysticercus.
We have to look it again at that lesion and maybe see it again.
Usually tubercular can present in an intracranial way also. So tubercular granuloma does present, although they have very similar presentations
For
in the
me,
brain.
I'm not entirely convinced
Neurocysticercosis
that.
and both.
Yeah, so I'm not entirely convinced that this aggressive end-off, which has led to unfortunately evisceration, can only be attributed to mycobacterium tuberculosis.
Yes, I also feel the same.
Yeah, Atul sir is also there if he can comment.
No, really, Pranav, really, I'm clueless about this case.
Yes.
Mm-hmm.
But have
I
you
don't
seen,
know.
sir, any tubercular case
No,
presenting?
I have seen cases in which the the culture are negative, because many a times we are doing the culture, we are not going for the PCR only. We are doing the culture and cultures are negative, but PCR negative, and then
Is rare.
it comes with the tubercular positive on evisceration with so fast deteriorating in the only in the 10 days. I'm clueless.
Unlikely. I think Dr. Anu has joined.
I don't know what happened with my connection, maybe. I don't know.
Yeah, please continue, madam.
Yeah, just a second. Just a second.
Do you have another speaker after her?
Yes, Dr. Rachna ma'am is.
Okay. Last.
I'm there. Speaker, sir.
I'm not able to share my. Now the screen is visible now?
No, madam.
Yeah.
In the meantime, we can ask Dr. Rachna to continue with her talk, and then we can have the remaining part of the
discussion afterwards. Okay, I'm sharing now.
Yeah.
I'll ask Dr. Rachna ma'am. She is an additional professor in Department of Ophthalmology, SGPGI, Lucknow. Her topic is beyond the bulge and intraconal orbital mass through a transconjunctival approach. Ma'am, over to you.
Just a second. मैं कहाँ चला? Zoom चला गया?
There's a share button.
Just a second.
Yes, ma'am. I'm
not able to wait.
Dinesh ji, if you can see if something is happening. Allow.
Now I got it. Is it okay now? Is it visible now?
Yes, yes, ma'am. Slideshow.
So I start with mine. Okay.
Yeah, ma'am.
So I'm presenting a case on proptosis. Usually, it is mostly for the PGs because usually they are scared when they see the word proptosis and it's scary for them. So I'm presenting a case of proptosis, how to take this case basically. So this case, this patient, 33 years old gentleman, he came to our OPD and he had a painless swelling. He had a painless swelling in the right lower lid, as we can see. So it was gradually progressive. So painless means painless is important and in the right lower lid. Then he presented with an upward deviation and swelling in the right lower lid. It was insidious in onset and progressive in nature. So we thought if it is congenital, so old photographs, it did not show any mass 15 years back. In general assessment, it was all normal. Then ocular assessment, the head posture was normal. The right eyebrow, as we see, is slightly tilted upwards because the mass is pushing the eyeball upwards. Then there was a fullness in inferomedial aspect of the right eye lower lid. On inspection, there was right eye proptosis, very obvious, and this was an abaxial proptosis. Axial proptosis is when the eyeball comes out, and abaxial is when it eyeball goes in either direction. It does not, if it is not, the pathology is not intraconal, but it is extraconal, then we have an abaxial proptosis. Now on palpation, we can see a smooth, firm anterior surface mass was palpable, and on Hertel's exophthalmometry, it was 22, proptosis was 22 on the right side and 16 on the left. So there was marked proptosis, as we can see. There was no bone erosion, and overlying skin was stretched, but it was pinchable. And fingers was not, could not be insulated between the mass and the medial wall. So puncta was displayed supralaterally, Roplast test was negative, and syringing was patent. So that means the lacrimal apparatus were not affected, although the swelling was in the medial side. So there was no rise in temperature, no tenderness, pulsations, thrill. Why are we checking for thrill? Because we are suspecting CCF also. Lymph nodes were not palpable. Lymph nodes important in case of infection and malignancy. Auscultation, we have no bruit, again pointing out that CCF might not be possible. So we did a full examination. The horizontal fissure height was slightly increased in the eye, and otherwise it was normal. Corneal sensation is very important. We have to test for all the cranial nerves because it tells us where the extension might be. If V1 is normal, V2 is normal. So that means it has not extended to the apex or to the brain. If V1 is involved, that means apex of the orbit is involved. V2 is also involved. That means the lesion has reached the cavernous sinus. So this way we rule out things. Thrill was absent. Post-bend test, again, it's important. Post-bend test is important because we can suspect varices, and varices was not there. Then we did an IOP, which is important. The vision was normal. Everything was normal. There was no diplopia, and extraocular movement was normal. That means the lesion is not sitting on the muscle, the extraocular muscle. Conjunctiva, the anterior segment examination was almost normal, within normal limits. The provisional diagnosis, based on the right eye, acquired because it was not congenital, chronic because the onset was insidious, gradually progressive, abaxial, not axial proptosis, supralaterally because the lesion was inferomedially. Now the provisional diagnosis can be mucocele, nasopharyngeal tumor, granuloma, schwannoma, cavernous hemangioma, neurofibroma. So we have the whole list what can be present. We got the blood investigations done. They were almost normal. So we ruled out infection. Now, the most important scan, the contrast enhanced MRI scan. So we can see in the contrast enhanced MRI, this is the T2 image because vitreous is white. So in the T2 scan, we can see that how there's a hyper-intense lesion, and it is a fusiform extraconal mass. It is pushing the medial rectus towards the cone. So it is not involving the medial rectus, but pushing it. Similarly, we do not see any bony erosion. So this points out that the lesion is benign and not malignant. This is what we can make out from MRI. It is abutting the globe and compressing and displacing the MRI. So in P1 lesion, we can see it is iso-intense to the brain structure. Like it is not It is iso-intense. So our provisional diagnosis was midline granuloma, schwannoma, cavernous hemangioma, neurofibroma, solitary fibrous tumor. Then the patient underwent transcaruncular inframedial orbitotomy. So this is how I do it. So what we do it? So this is a video. What we do it? We go transcaruncular, like we transconjunctival. So we make an incision 4 millimeter below the tarsus, where the tarsus end. We do a lateral canthotomy and cantholysis. Canthotomy and cantholysis give us the room to approach the orbit. Then we reach the periosteum, we go through it, and then you can see the lesion. Hello?
Visible. Is the video visible? Anybody else?
No, sir.
No, the video is not visible, madam.
Ma'am, if you can please.
Are you able to see it now?
directly.
No. We are only able to see the PowerPoint, not the video.
Okay, let me see if I can share it.
Just open it separately, ma'am.
Yes, that would be better.
Are you able to see it now?
Yes,
Yes,
now
yes,
it's much
yes.
better.
Okay, so
Can you start it from the beginning? Yeah.
So what I did was, I just made an incision below the tarsus, 4 millimeter below the tarsus in the lower lid. I did canthotomy and cantholysis so that more space is there. And then after reaching the periosteum, I did the subperiosteal dissection. So I reached the extraconal space. There I separated the tumor. Now it is important that we separate the tumor from all its adhesions. At least 70% of the tumor when it is separated. Then we do a cryo extraction. We put a cryo probe and then we extract the tumor. This tumor was encapsulated and it was not adherent to the underlying structure. So it easily came out. It was not an adherent tumor. So you can see we are just pulling it with the help of a cryo probe, and it is a big tumor, not a small one, as evident in the MRI. And we are pulling out the tumor. So you can see how it's done. And after pulling out the tumor, we are going to cauterize the stump. We are going to cauterize it. We are going to put bone wax or something to control bleeding. I usually use Trenexa also to control bleeding, sometimes when it is much. Otherwise, it's okay to a pressure bandage also suffice. So this is a big lesion which we got. And the whole of the mass came out in toto, like there was not a breach. So it went for histopathology, and histopathology, it showed, I think now this patient, this was the previous view before operation and after surgery. This is just 2-3 days after surgery. So the patient, because we did not go through the skin, we went transconjunctivally. So recovery is very fast. And the diagnosis came out to be solitary fibrous tumor. So solitary fibrous tumor, it's like cavernous hemangioma also, but we see the mitotic activity because it is a benign thing, but then it is mitotically active. It is like if the mitotic activity is high, then the patient has to go for radiotherapy also. But this patient, it had a low mitotic activity. So we've referred the patient to radiotherapy. It was not needed and patient is on follow-up and he's doing well, like he's okay. So the algorithm for approach to a case of proptosis is basically there should be a proper history taking because it was a painless swelling. So we came to know, yes, it is not a infection otherwise it would have been an infection. Systemic and ocular examination. All the cases of orbit, the systemic history and systemic examination is very, very important because like in the previous case, there was an endogenous endophthalmitis and it reached the eye. So I think systemic examination is important in each and every ophthalmic case. Then specific examination of the proptosis, as I had shown. Then arrive to a provisional diagnosis, get the imaging and the blood investigation done. Revision of the provisional diagnosis when you have all the investigation. And then plan the management based on the cause of proptosis. So thank you so much.
Thank you, ma'am. That was beautifully illustrated. Uh, I would invite the chairpersons to take it forward. Dr. Anubhav, sir.
Yeah. So, beautiful presentation, ma'am.
Thank you so much.
Not sure how much input I'll be able to give you because whenever I get a case of proptosis, I'm almost like a JR1 referred to an oculoplastic surgeon. So Abhishek will be in a much better position to answer our queries.
Ma'am, the only concern is in such kind of tumor, you
Mm-hmm.
did surgery very well, no doubt about it. But we don't
Mm-hmm.
know whether the tumor is adherent to the underlying tissues because you are very able to just take it out the whole way in a very, very nice pattern. Sometimes what happens, the tumor is attached to the underlying tissue, and then how can you go behind and dissect with the small incision that you have made and dissect the tumor and not damage the surrounding structures like the
See,
muscles and other things?
Uh, yes, very interesting. What happens is once we get the patient, we have to discuss this with the radiologist. Like before you operate a tumor, it is very important. There's a surgeon himself and herself. He goes to the radiologist and discuss it because a radiologist can easily tell what kind of adherence is there. Because few of our cases they are adherent to the lateral rectus or the medial rectus, but then it is like then also we go about it explaining the patient that a squint can be there after surgery because you have to remove it even
Right.
if it is adherent to certain muscles or tissues. You have to remove it. You have to be a bit radical in those cases, but yes, if it is important then you have to remove it no matter is this adherent and how much adherent that its orbit is like a Pandora's box. Unless you open it, you do not know what is installed for you. Sometimes the radiology says something and you get surprises on the table. But yes, by and largely, then you go for incision biopsy. If the case is such that you are not able to take it out, then you go for incision biopsy instead of excision biopsy. And if you are actually damaging the tissue around.
So you have gone mainly via the caruncular area or the inferior area in this case?
That in this case, it was medially. So not caruncally, but I just went through inferiorly only. I could, matlab transcaruncle also we can go because it was
Yeah.
medial, but in my case, I was able to, transconjunctival, a big incision, almost up to the caruncle, and I was able to take it out.
Thank you so much, ma'am, for the wonderful.
Thank
Dr.
you so much.
Just one question.
Mm-hmm.
Very good case actually. So, where exactly the tumor was sitting?
See, as you can see in the radiology, also the tumors was sitting. It was in the extraconal area, like you
Okay.
have the entire cone where you have the eyeball and the four muscles. They grip the eyeball, and there's a space between the medial rectus, beyond the recti muscle and between the ethmoid bone. So the tumors was sitting between the medial rectus and the ethmoid bone.
And then why you have chosen only the transconjunctival approach?
Because I thought that it was inferior and medial, so I could easily take it out.
Okay, okay.
Had it been a bigger one and I couldn't have taken it out, then I would have extended my incision
Medially.
medially. But luckily, because medial, there is very less space because you have that bone, the nose bone, so you cannot, take it out, and you have the sinuses also. But then I had extraconal, there is ample of extraconal space. There is a big space extraconally. So I was able to take out. Once you do a transconjunctival, the lid hangs, the lower lid, even if you go separated, so you have ample space to take out the tumor. This you have to judge before doing surgery that whether it can be taken out this way or not. But usually all the tumors that are inferior, medial and below and lateral and below, we are able to take it out transconjunctivally. Only the superior lesions we are not able to approach transconjunctivally because there you have to give a styloid incision or we have to go directly through the skin, or there are big incisions, then we have to do a lateral orbitotomy and then take out the big tumors. And still bigger, if they go to the brain also, then craniotomy and take out the lesion.
Otherwise, it seems like a big tumor.
Yes, it was a big tumor. It was quite a bulky tumor.
So
Yeah,
Dr.
yeah.
Rachna, did you hook the medial rectus muscle to like safeguard it, or how did you?
Yes.
Yeah.
Ideally, in whatever quadrant the tumor is, all those muscles need to be hooked. Like it was in the medial quadrant and the lower quadrant. So inferior muscles and the medial rectus both had to be hooked
Okay. Yeah.
to save the muscle. And at all point of the surgery we have to take care of the pupil, because if the pupil is constricted, like pupil is dilated, sorry. So that means optic nerve is affected. So at all times you have to take care of the pupil, that we do not touch the optic nerve, because once we touch the optic nerve, the patient might lose the vision.
So thank you so much, Dr. Rachna, for the wonderful presentation.
Thank you so much. Thank you so much for having me.
Yeah, thank you. And now, Dr. Anu, if you are
Yeah.
ready with the presentation, we can just finish off that presentation.
Yeah. I don't know. So my screen is visible now, I think, my slide.
Yes, not
Yes,
yet.
ma'am. Yes.
Yeah, okay. So this was the profile that I was talking, the usual tuberculosis profile that we expect in a usual case. But in our case, the patient was fully immunocompetent with no contact history, with double negative PCRs and no evidence of any systemic tuberculosis. So that was the catch. So basically, this fulminant endophthalmitis was just a visible, painful tip of the iceberg, which harbored disseminated intracranial tuberculoma and systemic immune energy. So systemic immune energy was the reason that why we had Mantoux, which was negative, IGRA negative. Why? Because there is in fulminant inflammation, vast antigen load. They can cause immunological exhaustion or energy, rendering the standard sensitivity test useless. So probably this was the reason in such cases. And about the pathogenesis, we could recollect that she had a episode of fever and vomiting 10 days prior, which might have been the reason for subclinical, which might have been the presentation for subclinical bacteremia that time, and which had led to hematogenous seeding, where Mycobacteria tuberculi, they must have lodged into the vascular choroid. And then subsequently, there was formation of choroidal abscess, which we saw on the day one she presented to us. And with the worsening inflammation, there was liquefaction, necrosis, and vitreous breakthrough leading to the endophthalmitis. As far as the diagnostic yield of PCR from aqueous vitreous samples is concerned, now there's been a systemic review of about 38 cases by Anteki, just concentrating on tuberculous endophthalmitis. And they only summarize that the highest yield is from the enucleated or the eviscerated tissue. And we do not get much from the aqueous or vitreous samples, because we know that tuberculosis is fundamentally a paucibacillary condition. Nonetheless, upgrading the diagnostic protocol to ask for a multi-targeted PCR will give you somewhat better sensitivity. So we should always order for PCR asking for multiple gene detection rather than single targeted PCR. So the last that we could do for that patient is give her cosmetic rehabilitation with the help of ocular prosthesis. She has already completed 10 months of ATT, and she is in regular follow-up. No fellow eye involvement whatsoever has been noted. And even the neurological the follow-up is there. And I think the tuberculomas are also on the resolution. So now at the end, I would just like to share this page from Ministry of Health and Family Welfare. It is about the TB Mukt Bharat Abhiyan, and they have a real-time ticker on their page, which shows that it was last updated on 8th June, and we are not even halfway in the year, and we already have new cases, more than 11 lakhs new cases, and many of them must be extrapulmonary TB. So I'd just like to end my discussion, leave you all with this. Tuberculosis is as old as humanity itself. Only by working together can we turn the tide against this Asian killer. Thank you.
Thank you so much, ma'am. A very well documented case. I would request the panel to discuss on the topic.
Excellent documentation, Anu. I probably missed it in your presentation. Do we have a gram staining and culture report for the vitreous?
Yes, sir. At that time also, gram staining was also done at the time when we did a vitreous aspirate, and they said that some gram negative bacilli they can be seen, but we are not sure. So with the
Didn't grow up on culture.
Blood culture. We did blood culture, not the vitreous or aqueous culture. So blood cultures were negative because if it was an endogenous thing, so negative.
Did you take a tap or a biopsy sample?
So the aqueous was tap on the day one itself, because currently we are doing a project on multi-targeted PCR from aqueous. But then vitreous, for vitreous, it was biopsy. Yeah.
It was like a normal biopsy.
Yeah.
It is pretty rare for PCR to come negative in these cases.
Yeah, I don't know. Maybe again, it was a single gene only, and we are doing CB naught for vitreous for tuberculosis. So I don't know what happened, but yeah, definitely the case was devastating for the patient and for us also as clinicians. You know, it ran so fast, and we could hardly save anything.
Madam, actually, you were discussing when your slides went off that usually the tubercular infection is not that fulminant, that it leads to evisceration in a month's time or something like that. It is usually a slow growing thing and does not have that strong thing. That was very unusual in this case. It may be possible, one never knows, but this was something which was very unusual in this case.
Very unusual, sir. And even this systematic review that I was talking about, they also said there were mostly the time period from presentation, the average of all the 38 cases, the time period from presentation to evisceration or enucleation, if that happened, because it happened in more than 90% of the cases of endophthalmitis, tubercular endophthalmitis. So the average time was around 3 months, but we hardly got any time.
And usually it is much more with the immunocompromised people with HIV, which we see the choroidal abscess and these type of abscess with TB, not usually in immunocompetent patients.
Yes, sir. Yes, sir. That was it. That was it. So very unfortunate, but I always wanted to share this, this case, so that it may be a learning, that maybe then some of the people, they said ki, then that means we should have gone for MRI at the first place also. We should have a whole body check. But then how do you explain it?
No, it's very unlikely.
Yeah.
So the take-home message is that TB can present something like this, and we should always have a suspicion for TB in such kind of presentation, so that we look, because see, losing the vision and losing the eye in front of your eyes is something which is very bad for all the ophthalmologists.
Very
So in case if we can save, definitely we should try to do other things. But your case was very, very unusual. Dr. Atul, any comments?
I think the case has got us all speechless, basically.
Yes. Could you hear me, Dr. Atul?
My mic is on.
Yeah, but we are not able to hear you.
Okay.
Yeah, now speak again, please.
No, really, I have no idea about this case, because so fast destruction with the TB, I have not seen.
Yes, the same with me also.
Yes, sir.
And sir, I want to share that for the second vitrectomy, the patient had gone to AIMS also. I mean, we did the first one, but because she did not respond, then we sent there, and they also did a vitreous PCR. I don't know. Then finally, the evisceration was done by us because patient kept sticking to us.
But ma'am, in PL negative eyes, do you operate in these cases also, or do you go for an evisceration? Because I think the first vitrectomy was also done when the patient had already become
PL positive. At that time, it was PL positive. Yeah.
So thank you, ma'am, for your wonderful presentation.
Thank you.
So Pranav, please carry on.
Yes, sir. So we'll move on to the next speaker. I now invite Dr. Atul Dhawan, sir. He is the Chief Retina Consultant at ASG Hospital, Kanpur. And he will be presenting OCT-based sequential structural changes and tissue remodeling after flap closure following inverted ILM flap surgery. Sir, if you can share your screen.
Thank you, UPSOS, for this opportunity. Today, I am going to present the wound remodeling after the macular hole surgery. And this is, one second. Can you see my slides?
Yes, sir. Yes, sir.
One second.
You'll have to click.
Clicking, but it's not coming. It's showing your.
We can see your slides, sir. The primary slide.
You can see now?
Yes, 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 sir.
So wound remodeling after the macular hole surgery. So before going for the wound remodeling, few words about the foveal anatomy and the macular hole surgery. In short, so this is the normal fovea. Everybody knows 10 layers are there. Few things I want to tell you here, which came into the picture after 2019, after the paper of Dr. Brinjman. He has classified this in the center part. There are two types of Muller cells are there in retina. One is foveal cone Muller cell and the other one is the foveal wall Muller cell. The cone Muller cell is in the central part, which is holding the fovea at the center. The foveal wall Muller cell is at the slightly periphery to this. Now, this foveal cone Muller cell acts as a favicole, which is holding the fovea and making it a U shape. This is not a normal position of the fovea. This is not the resting stage of the fovea. This is a constant tug of war is going on between the centripetal and the centrifugal forces are there. At this time, the centripetal force by the foveal cone Muller cell, which is at the center, is more than the centrifugal forces. Now, from where the centrifugal forces are coming? These are by the nerve fiber layer and by the vitreous. So at this time, this centripetal force means towards the center is more than the centrifugal forces. That's why the fovea is intact. Now, how the macular hole forms? The macular hole forms when the centrifugal force, means the force away from the center of the fovea, is more than the centripetal force, which is the centrifugal forces by the vitreofoveal traction and by the nerve fiber layer. So in this process, the foveal pseudocysts form, and after that, this leads to full thickness macular hole formation. Now, what is the response of the retina? If any break is there in our skin close itself, heal itself spontaneously. The same thing is going on in the retina also. There is whenever there is a macular hole formation, this foveal wall Muller cell, they increase the concentric contraction forces. They want these inner edge of the macular hole comes nearby, and these are like favicole. So they will attach to each other. They will close the hole by itself, and later on there is centripetal migration of the photoreceptor. So the hole which we are seeing on the slit lamp, it is not the first hole. Maybe 2, 3, 5 hole already was there and they were healed spontaneously, but this hole is still open. Now, the reason why this hole has not closed spontaneously is 3 reasons are there. The hole is so large that even because of the concentric contraction of the foveal wall Muller cell is not able to meet the foveal, the both side of the macular hole, approximate both side of the macular hole to each other. The second one is the centrifugal forces of ILM plus ERM, which is directed away from the macula, away from the fovea, is more than the centripetal Muller cell force. The third one is the combination of both. So how can we help the retina? We can help the retina as a best friend either by removing the tangential traction, that is either by ILM peeling or by the macular massage, or we can close the hole artificially either by the ILM flap, amniotic membrane, retinal tissue, and somebody are using the fibrin glue. Mudit is using the fibrin glue also. So first I am telling you a case in which I have used the inverted ILM flap technique. For the inverted ILM flap technique, three basic principles are there. One is how much the flap big should be, how to make a good flap, and how to keep the flap overhold till the last part of the surgery. These 3 points are the key points for the macular hole surgery by inverted ILM flap. So how much big the flap should be? The flap should be as big as possible. Why? If we'll go to the class 10th or class 11 physics, we will find out if two glass plates are separated by a thin layer of liquid, then the natural force which is required to separate these plates is directly proportional to the area of contact. That means if here we apply this, if the flap is large, the natural force should be much more stronger than in the case of the smaller flap. The second one is, and this is the simple way how to make the flap. And I was there in Chennai for 17 years, so I have termed it as a dosa technique. This is the simplest way. As you flap the dosa, the same way you put the flap over the hole. Now, these are the three layers of retina. The brown one is the layer RP, the orange one is neurosensory, and the blue one is the ILM. Now, how to make a flap? Simple thing. Around 200 degree imaginary line, make small cuts, join the cut with the help of either Finis loop or by the ILM peeling forceps. Put the flap over the hole with the help of ILM peeling forceps. You should be very delicate in this procedure because it's a 4 micron layer and we don't want to tear up this. This is a very, very important step. And how to keep the flap over the hole till the last part of the surgery? It's easy with the help of the flow of the fluid. When the fluid air exchange is going on in the last part till the eye towards the disc side, the fluid will act as an ironing tool to keep the flap over hole. And for what I am doing now from the last couple of years, after had a good discussion with my very good friend Wilson, 10 minutes of drying. This drying make the cavity total dry and keep the flap over the hole for the next couple of days. Now, this is the case in which I have done the inverted flap technique. This is the pre-op case left side and post-op case on the right side. You can see stage 3 or stage 4 hole was there. 2 years back, I have done the surgery and this is almost 17-month follow-up on the right side. 17-month follow-up on the right side, you can count all the 10 layers with V-shaped closure. Pre-op vision was 660, post-op vision was 612. Now, if you see closely, all the 10 layers are present, starting from the RP, then the ellipsoid zone, then the ELM, then the outer nuclear layer, and all the layers, they are, you can count every layer with properly distinct margin. Now, I'll show you how the case progressed with time in this case. This was 11th of March 24, and I did the surgery on same day. After that, surgery, and then inverted flap, then ILM, then inverted flap, then SF6 gas, followed by 5 days prone position. After the gas has gone, you can see the hole was almost closed. Now, see closely, this is the central part. In the central part, you will see the hyperreflective layer. This hyperreflective layer is Muller cell. This is gliotic process going on. And at this time also, you can see the ELM almost formed. So the hole closes from vitreous side towards the disc side. First ELM form, later on the ISOS junction form. But before that, you can see this hyper-reflective material is there, and you cannot see the outer nuclear layer in the central part. Next is 18th of April. You can see the hyper-reflective layer is less. The ELM form, but still not fully. Now, this one is 22nd of July 2026, last picture. Now, if you'll compare from the previous pictures, you will find out all the layers are present. All the 10 layers are present, and the central gliotic tissue has gone, and you can easily see the outer nuclear layer from one side to the other side. In the last, I'll tell you what is the significance of this. Now, this is the second case. Sorry, in that case, that was not an inverted flap. That was a simple McLaughlin 360-degree ILM. This is the inverted flap surgery. You can see the surgery was done on 28th of February 2024, and the last OCT was 7th of July 2025. This is stage 3 McLaughlin. Large, almost 800 micron, the minimal hole diameter. The surgery was done, and now you can see in the inverted flap surgery, this is the flap closer. Dr. Zofia and her father, Dr. Navroki, Jerzy Navroki, who have invented this surgery, they have found out, or in their series, almost 14 to 16% of the cases are flap closer. Now, how this flap closer changes with the time, just see. After 1 month, you can see the hole was closed. The ILM flap was still there, but still in the center, you can see the gliotic tissue. Still, you can see the gliotic tissue, and the ELM and the ISOS junction are still away from the center. After some time, you can see ELM and ISOS junction move toward the center, and central gliotic tissue is less. With the time, almost ELM and ISOS junction form, still the gliotic tissue was there, but decreased in size. Now, after 6 months, you can see almost whole ELM and ISOS junction form. Still the gliotic tissue was there, but it is very less. This is after 1 year. Now, after 1 year, you can see the whole ELM and whole ISOS junction form. This U-shaped closure is there, and the most important thing is the gliotic tissue has gone. Gliotic tissue has gone, and you can see from one side to the other side the full outer nuclear layer you can appreciate. So the conclusion is two hypotheses are there. When in 2014, when Dr. Shiode and Japanese co-worker, they have done this, they have done the autologous ILM transplantation. Then they have given the theory of Muller cell de-differentiation, then re-enter into the cell cycle and change into the photoreceptor. Means Muller cell, which is the mother of all the cells in retina, starting from the ILM till the ELM, which is there. It is going back into the cell cycle and changing into the photoreceptor. One theory is this. The second theory is this glial tissue dissolve. In this process, it pulls the outer photoreceptor, the peripheral photoreceptors towards the center and form the ELM and the ILM. So both the theories are there, but the second theory is more applicable. So there is remodeling of the tissue after the macular hole surgery going on. Thank you.
Thank you so much, sir. That was an excellent sequential OCT documentation. I think the way you taught everyone, everybody would understand that they should go for an inverted ILM flap technique only in most of the macular hole surgeries. And I think recently most of the people have shifted to inverted flap only, even in smaller holes. So what do you think about that, sir? Do you do inverted ILM flap technique in smaller holes also, or you're doing it in all the holes?
Yeah, Pranav, this is a very debatable question, and people all over the world, there is no consensus.
Yes, sir.
People are many very famous and very knowledgeable retina surgeons. They are doing inverted flap in all the cases.
Yes.
But still, I am using the inverted flap as a rescue procedure. When till 500, 550 micron, I am going only for 360 ILM peeling. And after that, I'll go for the inverted flap technique. For me, inverted flap is not the primary surgery. But I don't have any support for this comment that inverted flap will cause decrease in vision or decrease in contrast sensitivity, any other thing. But it is personal choice. But I have seen the whole closure in 200, 300 or 400 micron, only with the 360-degree peeling, the contour is much better than the inverted flap technique.
Anshu, sir, if you have any comments.
Yeah, so actually what Sarah said is very valuable. Like you have to look at the size of the hole and also see the contour of the hole. So if you see the size of the hole, which is the most important, the basal base of the hole, if it is less than 600, my threshold is 600. So if it is less than 600, there is no need to do inverted flap, and don't be overzealous with flaps, because sometimes these flaps leave a kind of gliotic tissue over there, which is not a functional sensory retina. So in case of larger holes, yes, up to 1000 microns or 600 to 1000 microns, it's a very good choice to go for an inverted flap technique. And very beautifully he has shown the results with. I was a little surprised to see the first bit of series of the case which he showed, and he said that there's flap. I was missing the flap over there, so I was little confused with whether it was an invisible flap for me. But then sir has clearly clarified that it was not a flap technique for the first case. I have presented this way back, I believe, in VRSI around 8 years back, I believe, when this concept of, the visual prognosis depending on your, whole biomarkers, which suggest that you can have a good outcome, is the most important of them is restoration of the external limiting membrane. So if you have, the external limiting membrane healing up well, or as Dr. Atul has said, that the way the cells modify and they move towards center in a centripetal manner and create, the layers subsequently is seen like in most of the cases which are closing well. So same, nothing else to add. That beautifully depicted diagrams and beautifully depicted OCTs. It takes a lot of effort to go back to your OCT scans and document these things and look at these things at a very microscopic level. Very nice, Dr. Atul. I would appreciate. I appreciate that.
Thank you.
Anupam, sir.
Sir, your choice of gas in macular surgery is SF6 in all cases?
Yes, yes. I think after 2013, I have not used C3F8. And air I am not using at all.
Why are you not using C3F8? Any particular reason?
Why to? No, we need only for maximum 5 days tamponade. 5 days tamponade. The gas will be there for 48 to 60 days. The patient cannot go anywhere. Patient cannot fly. Patient cannot go high-rise building. If you are living in 15 floor or 20 floor, you cannot go there. So better is and what is the use of a substitute which is not required?
No, that's fine. So just to make a small comment, very well presented the formation of macular hole and how it heals, especially for all the postgraduates who are seeing this. Very excellent presentation. My only consideration was that after in the post-operative period initially showed was there was a strong ISOS junction damage which was there. And with time you have shown that they are healed to almost like a pre-macular hole area. So do you think that because what we have learned, I'm not a retina specialist, but what we have learned that once the ISOS junction damages, usually it does not become the same as it was before. So what's your comment on that?
No, that was the conclusion point, that two hypotheses are there. One is, in the process of closing the hole, the Muller cell pulls the photoreceptors towards the center. Means if suppose 100 photoreceptors are there and 30 photoreceptors has gone during the macular hole formation. So Muller cell contraction theory will lead to those 70 which is away from the center of the fovea. They will get 20-30 towards the center, because body knows more than us. We have evolved in the 4 billion years, so we don't know what is going on. One is this, that the photoreceptor migrate from the peripheral macula to the center of the macula. The second theory is the Muller cell again go into the de-differentiation, again go into the cell cycle and change into the photoreceptor. Means one cell which is already differentiated now going back into the cell cycle and change itself for the vision purpose, means body knows much better than us which cell is required where, how to see the thing. Means we are we are maybe after some time, after 10, 20 years or 30 years, we will find what is going on in this process. We don't know. We are just helping. We are not doing anything in the macro hole surgery. We are just helping the natural healing process. We cannot do anything. We cannot make a simple cell. This is the end point. We cannot make a simple cell. We cannot go and tell the photoreceptor, okay, you are away from the phobia, come inside and start working. So this body knows much better than us.
Great, sir.
Thank you so much, Dr. Atul. Pranav?
Thank you, sir. Yes,
So
sir.
you practically
Sarita
mean to
ma'am?
say that these cells work as a pluripotent stem cells. They tend to grow up from being a Muller cells to a RT.
Yeah, sir. The same words used by Dr. Shiode, and 2004 paper is also there. 2006 paper is also there. That cells de-differentiate. Cells de-differentiate, and then again they go into the cell cycle and form the photoreceptor. But how much extent and how much is going on, it's very difficult.
Okay, sir.
The way in inverted flap surgery, the way the healing process is going on, in 2017 or 19 paper, Dr. Shiode has done 2 monkeys' eye, and then he sacrificed the monkeys, and he has shown how the cells go inside the flap and form a gliotic tissue, and then there is whole closure is there. So 2 theories are there. I don't know which one is correct, but body knows much better than us. This is the last.
Thank you so much, sir. Sarita ma'am, if you have any comments, or we'll move on to the next speaker. So I think our final speaker for the evening is Dr. Monica Arora, and she is a glaucoma specialist and an assistant professor at RIO Sitapur and former senior resident at RP Center, AIMS, New Delhi. Her topic is post-Adi hypotony, all well that ends well. Ma'am, please go ahead.
Good evening, everyone. My slides are visible.
Yes, yes. Can you do a slideshow, ma'am?
That I've done it. I would like to express my sincere gratitude to UPSOS for giving me this opportunity. So I'm directly coming to my case. 26-year-old, one-eyed male who underwent trabeculectomy with mitomycin C of the left eye in 2016. On 6 January 2024, the vision in left eye was 636 with an IOP of 52. Just a minute, sorry. With an IOP of 52, there was a near total cupping and the patient was started on the maximum medical therapy. The patient had a history of loss to follow up, and the patient came back in November 2024 with a vision of 6/36 and an IOP of 42 millimeter mercury, and the patient was advised for glaucoma wall surgery, but the patient refused at that time. Again, the patient came in March 2025 with a vision of 3/60 and an IOP of 36 millimeter mercury, and again the patient lost to follow up. The patient came back in October 2025 with a vision which was deteriorated to hand movement with an IOP of 42 millimeter mercury, and the patient now agreed for the surgery, and we planned a glaucoma drainage device. In the right eye, it was a phthisis bulbi, whereas in the left eye, it was a megalocornea, HAPS stria. Superior surgical iridectomy was present with the iris atrophy with mid-dilated fixed pupil, and there was a total cupping. So the diagnosis in the right eye was phthisis bulbi, whereas in the left eye, it was a PCG with failed trabeculectomy twice. And the management was in the left eye, we planned Adi under subtenous anesthesia. So this is my surgery. So a corneal traction suture was taken. Pilocarpine was injected in the anterior chamber, and a conjunctival peritomy was done with a relaxing incision. Tenons was separated. The tube was primed, and a flap was made. Entry was done in the anterior chamber. A ripcord suture was placed in the tube. And the tube was sutured with sclera, with proline. The tube was placed in the anterior chamber as the patient was phakic. Two ligature sutures with 6-0 vicryl were placed. And the tube was secured with 10-0 nylon. The flaps were closed. And conjunctival peritomy was closed. So my surgery was uneventful. Nothing happened unusual in this case. But when I saw my post-op, saw my post-op, the AC was totally flat. The tube was touching the cornea, and there was a kissing choroid. So I took the patient for left eye AC reformation with tube ligature under subtenon. So I looked back my recording videos, what went unusual in this case. So what steps surgical steps could be modified so this post-operative picture was prevented. So one thing I want to say, two surgical steps which I modified in this was that whenever we are doing ligature, so there should be a kinking in the tube and there should be an hourglass pattern here. Hourglass pattern and two ligature sutures should be taken and priming of the tube should be done. That I didn't check that priming was not done. And the peritubular suturing should always be considered because there is always a seepage of aqueous from that area. So that leads to hypotony. So when I modified these two steps, the post-op picture was very good. So on 9th October 2025, there was vision was hand movement only. The pressure raised, it went to 22 and the tube was in place and AC was formed. After 2 weeks, the IOP again raised to 26 millimeter of mercury and we started one topical AGM. After 2 months, there was a formation of encapsulation on the plate and the ripcord sutures were removed and the patient is doing well. So this is a video of removal of the ripcord suture. So coming to the conclusion, PCG eyes exhibit increased scleral elasticity, thinning, and making them more vulnerable to hypotony and serous detachment following aqueous shunt surgery. Prompt recognition and surgical revision on post-op day 1 effectively normalize in intraocular pressure and facilitate the resolution choroidals without compromising long-term bleb function. While ADI provides excellent long-term IOP control, the immediate post-operative period requires vigilant monitoring due to risk of hypotony and IOP fluctuations before capsule formation. Thank you.
Thank you, ma'am. That was a very practical case and well managed. And the take-home message on early intervention is one we can all use. So I would request Dr. Anupam sir for his comments on this.
Ma'am, excellent demonstration of the valve. I just wanted to know if one can attempt a retrap at a different site before going in for glaucoma implants in these kind of cases.
Yes, sir, we can, sir. So, but actually 2 times surgery was done, sir, previously only,
Twice,
sir.
okay, I missed
Yes,
that.
sir. Yes, sir. Yes, sir. So the conjunctiva was already scarred, sir.
Sure.
Any other comments?
Dr. Monica, I have one question for you.
Yes, sir.
Usually we do this kind of glaucoma drainage devices for patients who have very recalcitrant kind of, glaucoma.
Yes,
And
sir.
when we do this procedure, I also do a lot of these glaucoma filtering surgeries for neovascular glaucoma and other recalcitrant cases. What I've noticed is, how do you, when you're taking your patient in, you tell him that we are going to do a procedure which is going to, solve the high pressure issues. And, these devices, they, valveless devices, you need to block them, and the pressure fluctuations remain so much that it is sometimes difficult to, explain to the patient that even after a procedure, the pressures are not going well. So how do you counsel your patient for these kind of situations?
So we explain to the patients that the IOP may increase after the surgery. You have to be in a close follow up. We will start the medications. Eventually, we will remove the sutures and the IOP may come down, or we can go for the needling also, sir.
Yes. So needling is one thing which I usually also do in the tube. Like we pass multiple, entry sites, side entry sites for the, initial part of the pressure control. So that also works very well, I believe.
Yes, sir.
Abhishek, sir.
Thank you so much, Dr. Monica. Wonderful presentation.
Thank you,
And
sir.
I feel that valve surgery is a little more challenging. It's not that difficult to do, but sometimes the results are quite unpredictable. For example, you showed the hypotony, and
Yes,
I've
sir.
seen the fluid leaking from the from the tube endings.
Yes,
And
sir.
because you cannot close the sutures very tightly because the tube is there, so you cannot
Yes, sir.
in a trap, you can firmly suture it. So sometimes that's also a problem. And with non-valve disease, then hypotony and hypertony, both factors are there. So anyway, well do to do, but that is the only solution we have in such kind of cases.
Yes, sir.
Very nice presentation, Dr.
Thank you,
Monica.
sir. Thank you, sir.
Uh, Thank you so much, everyone. With that, we come to the end of the evening's session. My sincere thanks to Dr. Arup sir for a wonderful keynote and to all the speakers for their wonderful presentations. Abhishek sir, if you want to say some
No,
words.
I really want to thank all of them, all the presentations, especially Dr. Arup, Dr. Atul, and all the presentations were very nice, very informative, and especially for the residents. So we will try to keep up with this webinar series. I think it's already 6 or 7 webinars we had in the last 6, 7 months, and we would like to continue it for the whole 3 years of our term. So thank you all the speakers and thank you all the audience for your wonderful hearing. And we wish to see you future in all our further future webinars. Thank you so much.
Thank you, sir. Good night, sir.
And good night.
Thank
Thank
Everyone.
you.
you.
Thank you.
Thank you.
Thank you.
Good night, sir.